واضحة يسار.
اوكي تمام. انا الاول يعني حابه اشكر حضرتك طبعا على الدعوه النهارده، وحابه اشكر ايمان جدا على الانترودكشن اللي هتسهل عليا كتير جدا في البرزنتيشن، و I'll try to be as brief as possible for the sake of time. البرزنتيشن بتاعتي النهارده عن another study was published in the Journal of Neurology اسمها randomized trial of vaccination in fungal treated patients with multiple sclerosis. kind of يعني همشي تقريبا على نفس السكيم اللي ايمان قالتها. هنقسم البيبر لبارتس، وهنبدا نيفاليويت كل بارت اذا كان فيل كل البوينتس that should be fulfilled. اول حاجه title. usually a title should clearly describe the clinical question. فمن التايتل اللي قدامنا احنا فاهمين هم غالبا عاملين randomized trial بيحاولوا يشوفوا is vaccination similar between fungal patients and non-treated MS patients. بس الدروباك في التايتل ان هم they fail to mention to what type of vaccine. بس honestly لما when we go through the details of the study هنلاقي ان هم لو كانوا حاولوا يفولفيل الموضوع ده كان هيبقى التايتل so long and complicated، فيعني they're justified in what they did. الauthor دول authors. It was a multi-center trial. Usually the first author, the junior author is the first one and the senior author is mentioned last. في نقطة في الفاندنج إن this study was funded by Novartis Pharmaceutical. وفي كده بيبقى فيه شوية caution لما يبقى فيه pharmaceutically funded studies بتخلينا يعني طبعا مش كل ال pharmaceutically funded بتبقى biased، لكن usually we should be extra cautious لما نلاقي study pharmaceutically funded نبقى extra cautious في ال criticism وفي إن احنا ندقق في تفاصيل الاستادي قوي to make sure that the results are valid. بالنسبة للintroduction, they actually cleared or highlighted most of the previous data and literature, which was not much, and they clearly stated the research question at the end of the introduction. ودي حاجة مهمة في أي paper عشان يوضحوا بالظبط إيه research question أو إيه الaim اللي هم بيحاولوا يوصلوا له للtrial. They described clearly the aim of the study. They wanted to provide class 1 evidence, and luckily in this case, this paper is a randomized control trial, one that provide one of the highest evidence. They wanted to prove whether the patient with MS receiving immunization with concurrent fungal treatment, is there any difference between those patients and the patients who receive placebo instead, against both null and recall antigen, وهنبين which vaccination they received. For the method, the study design was a very well-designed study. It was a randomized 2-to-1 double-blind study, placebo-controlled, multi-center, and with a duration of 12 weeks. So this is a very good design for the study. The randomization method, they used the validated interactive voice response or interactive web response. ده عبارة زي software computer program بيبدأ يراندمايز البيشنت وبعدين يبدأوا يحطوا البيشنتس في block of 6 ويبداوا يراندمايز السيكونس مين هياخد الستادي الدراج اوف ستادي ومين هياخد البلاسيبو. كل ده بيبقى generated عشان eliminate اي selection bias، لان احنا usually as physicians if we select the patient غصبا عننا بنلاقي عندنا في urge شويه ان هو البيشنت اللي عنده high EDSS score او indicated for certain treatment, we tend to randomize this patient to the treatment group, while patients who are doing much better ممكن نحطهم في البلاسيبو، فبيبقى في element of selection bias. ف randomization they eliminate this risk. Same for blinding. The blinding method can study medications. Usually ده في أي study مش هنا بس. It should be identical, both the placebo and the study, the actual treatment, in packaging, in labeling, in schedule of administration, in appearance, and in odor. In order not to uncover the blinding. يعني ممكن مثلا الدكتور أو البيشنت يعرف إن ده مش الستادي تريتمنت لو لونه مختلف. لو واحد بيتاخد مثلا IV واحد بيتاخد oral. لو واحد الباكجينج بتاعه أو ليه ريحة معينة، فالحاجات دي لازم كلها تبقى identical in order to maintain the blinding. The patients and investigator were both blinded to the study. هم قالوا بس هم they justified إن هو كان for logistical reasons. ساعات كان بيبقى فيه الستاف او الانفستيجيتور ممكن يطلعوا على معلومات ممكن تبقى potentially unblinding، زي مثلا الليمفوسايت ليفل او the 6-hour first dose monitoring. يعني مثلا patient تعرف الليمفوسايت كاونت بتاعه كان قليل شويه فبيديني suspicion ان البيشنت ده ماشي on the treatment on fingernail. بالاضافه لكده كمان عشان يزودوا يعني ميك شور ان البلايندنج موجود واديكويتلي ابلايد. اللاب اللي كان بيعمل الانتي بودي تايتر was different from the lab that measured the lymphocyte count and they were blinded to the lymphocyte count. يعني اللي بيميجر الانتي بوديز ما كانوش allowed ان هم يطلعوا على lymphocyte counts of the same patient. بالنسبه للبيشنت سelection هم they randomized 163 patients 95 to the fingerlode arm and 43 to the placebo بطريقه الراندمايزيشن اللي قلناها. والسامبل سايز was pre-calculated برضه بالconfidence interval وحسبوا الدروب اوت ريت was very adequately calculated. الage كان من 18 to 55 and they selected only remitting MS patients with EDSS ranging from 0 to 6.5. طبعا this is a very wide range of EDSS وده in order to attempt to generalize the results بدل ما ياخدوا very low EDSS أو very high EDSS. وكان كمان في السelection criteria لازم البيشنتس يكونوا receive the lifetime tetanus toxoid vaccination وبعد كده they were randomized زي ما قلنا 2 to 1 يعني 2 ياخدوا التريتمنت الفينجيلومود to 1 to placebo. لقوا يعني الراندمايزيشن في الاخر لما قارنوا البيز لاين characteristics of both groups كانوا more or less similar. دي برضو حاجه ثانيه ان هم overcome the selection bias. الحاجه الوحيده بس ان كان في ethical issue ايمان اتكلمت عن الموضوع ده ان هم those are all MS patients فان احنا deny of them treatment is kind of unethical بس هم they justified ان هم حاولوا overcome الموضوع ده ان هم they limit the study duration to only 12 week او 3 months. The patient they stated the duration of recruitment of patient can between August 2010 and December 2010 and then the patients were vaccinated between September 2010 and Jan 2011. وحطوا سكيم واضحه وفلو تشارت واضحه ل how many patients were assessed and how many patients were randomized with drop out rate and all patients were analyzed for efficacy and safety. ودي همنشن قدام اهميتها ايه ان all patients were analyzed. بس نرجع للاكسكلوجن كرايتيريا الحقيقه كان في very long list of exclusion criteria معظمها related لحاجات very logic الصراحه ان هو اي حد خد history of vaccine the same influenza vaccine that was going to be given in the trial they were excluded. Any history of influenza disease 6 months prior to screening, H1N1 vaccination or confirmed or suspected infection within the past 3 months before randomization, history of tetanus toxoid vaccination within 1 year before randomization, receive or expected to receive any live attenuated عشان they can't receive this while on fingerlode, history of serious reaction or allergy after administration of any vaccine, and they كانوا vigilant شويه كمان في النقطه دي ان هم اي history of chronic disease with a known immune deficiency, macular edema, malignancy, negative varicella zoster IgG antibodies, treatment with immunosuppressive drugs, or clinically significant cardiovascular condition or systemic disease. They kind of all make sense بصراحة to me بس هي الفكرة بس في last موضوع clinically significant cardiovascular or systemic disease I believe it was related to being treated with fingerlode but too many exclusion criteria might interfere with the generalizability of the results. يعني هم they excluded too many patients تخلي الواحد يكويستشن طب لو عيان MS وعنده cardiovascular disease the most probably مش هياخد جيلينيا بس لو عنده systemic disease and it's not contraindicated for fingerlode. فيعني الموضوع كان I think it's part of the limitation but I don't think it could have been avoided. They adequately described the intervention. Fingerlode were received daily, orally once daily. The first dose was given as per protocol with supervision of the investigator. After 6 weeks, they give single doses of the seasonal influenza vaccine and tetanus booster dose to all patients. And then they estimated the antibody titers at baseline, which was pre-vaccination, 3 and 6 weeks post-vaccination, which is 9 and 12 weeks after randomizations. And the patient, they received the vaccine 6 weeks after being on treatment. They were all treated or vaccinated, with the injectable 2010-2011 with a certain brand of vaccines that's available. لو في countries, and it was a multi-center, they gave the equivalent vaccines approved in those countries, and all vaccines were given according to the manufacturer label. They described adequately ودي one of the very good points اللي عجبتني ان هم they described exactly الانترفنشن اللي عملوه. رجعوا بعد كده described بالظبط ايه الاسسمنتس اللي عملوها لهم methods of assessment. الانتي titer against influenza vaccine was measured with hemagglutinin inhibition نفس الميثود اللي كانت ايمان قالتها في الترايل of interferon against tetanus toxoid using ELISA technique. And then the immune response were determined by the change in the antibody titer between the pre-vaccination and post-vaccination time points. نرجع للنقطة الثانية ان احنا قلنا all patients, even those who dropped out, they were included in the primary analysis. They wanted to apply what is called intention to treat analysis, which is all the patients should be included in the analysis, even those who failed to complete the trial. They tried by this ان هم overcome حاجة اسمها لما يبقى فيه too much drop out rate أو too many patients مش بيكملوا trial. This might result in some sort of bias. Even though the drop out rate can vary in both arms. يعني تقريبا في البلاسيبو ما فيش ولا واحد dropped والarm of الفينجليمود I think 2 patients only dropped. They described the primary outcome. The primary efficacy variable was the responder rate to seasonal influenza vaccine at 3 weeks post-vaccination. ده كان البرايمري outcome. بعد كده في secondary outcome وبعد كده هم define يعني ايه برضه responder rate. السكندري outcome كان بقى الريسبوندر ريت للانفلونزا at 6 weeks والريسبوندر ريت للتيتانس توكسويد at 3 weeks and 6 weeks وقاسوا حاجه ثانيه اسمها inhibition of immune response to each strain اللي كانوا included في الفاكسين اللي هي كاليفورنيا والبريسبان and the Perth strains and to tetanus toxoid booster dose. يبقى عند 3 ده الاساسي عند 3 اسابيع وبعدين عند 6 للانفلونزا وعند 3 و6 للتيتانس توكسويد والinhibition of the immune response for patients on fingolimod. كان في كمان outcomes سموها exploratory efficacy variable. دي كانت حاجات extra added بعد كده. السيرو بروتكشن كنت العيانين already كانوا سيرو protected all from the beginning. سيرو conversion العيانين اللي اتحولوا من سيرو نيجاتيف لسيرو بوزيتيف. A significant increase in antibody titer against the influenza vaccine or tetanus toxoid and حاجه اسمها geometric mean antibody titer pre and post vaccination. Actually قبل ما اكمل الجيومتريك مين انتي بودي يعني حاولت افهمه هو it's kind of more accurate measure احسن من المين شويه بس الغريب ان انا لقيت معظم اللي منشنت ان هي بتبقى بتستخدم اكتر في الفاينانشال ريسيرش. هي بتبقى عباره عن السكوير روت بتاع الفاليوز المالتيبلايد فاليوز يعني بيضربوا الفاليوز في بعضها وياخدوا السكوير روت بتاعها وده بيبقى اسمه الجيومتريك مين انتي بودي. رجعوا بعد كده عملوا clear definition ودي برضو حاجه من ال very good points وال strong points ان الموضوع كله كان objective 100% ما فيهوش اي نوع من انواع subjective measures. الريسبوندر ريت قالوا ان هو كان defined as the proportion of patients showing seroconversion or significant increase in the antibody titer between pre-vaccination and post-vaccination. ورجعوا عرفوا significant increase بان هو 4-fold increase في الانتيبودي titer. وقالوا ان ده مش شرط يكون for the 3 strains but at least for 1 strain. فده كان considered responder rate لو he responded to only one of the 3 strains contained in the vaccine. سواء كان للإنفلونزا vaccine أو للتيتانس booster dose. الانهبيشن of the immune response عرفوه بان هم جابوا الريشيو بتاعه الجيومتريك مين antibody titer at certain points يعني for example at 3 weeks خدوا المين بتاع التريتمنت بتاع الفينجليمود على المين بتاع البلاسيبو وطرحوا الاوتكم من 1 وحسبوها ببرسنتج ان الفينجليمود عمل انهبيشن للاميون ريسبونس بالنسبه دي. ده بالنسبه للميثودولوجي. بالنسبه للريزلتس رجعوا قالوا ان البيشنتس 1 3 8 patients 95 on fingolimod and 43 on placebo دول the total patients. دي highlighted كذا حاجه ان كان البيشنت عندهم high pre-vaccination rate او antibody titer against one of the strains. في البيرث سترين دي already العيانين كانوا بادئين سواء on placebo او اونجيلينيا البري فاكسينيشن ليفل كان عالي قوي فده خلى شويه ريزلتس للسترين دي ما تبقاش significant زي بقيه الريزلتس اللي هنشوفها. ولقوا ان more or less الديموغرافيكس والبيزلاين كاركترستكس كان between the two groups the same وده اللي احنا قلناه في الاول عشان ما يبقاش فيه اي compounding factors او اي في difference between the two groups. البرايمري اند بوينت اللي قلنا ريسبوندر ريت للانفلونزا فاكسين at 3 weeks لقوه في الفينجريمود treated patients 54% versus 85%, and this was significant. وعن 6 weeks لقوهم 43 versus 75, and again this was significant. نفس الكلام كان بالنسبه للتيتانس بوستر دوز وعند 3 اسابيع وعند 6 اسابيع. الشارت ده كان لطيف جدا، كان مبين يعني الريسبوندر ريت بالنسبه للبلاسيبو اللي هو ان جراي، والريسبوندر ريت للجيلينيا، طبعا الفرق واضح جدا at 3 weeks و at 6 weeks. بالنسبه للانفلونزا فاكسين combined يعني ريسبوندد لاي واحده من السترينز، وبالنسبه للتيتانس توكسويد. بالنسبه لبقيه الفاريبلز قاسوا برضو البروبورشن اوف patients who met the criteria for seroprotection, conversion, and increase في الانتي titer to both influenza and tetanus booster dose at 3 and 6 weeks. هنا كان في مشكله بس في الجدول ده، ان الجدول ده بالنسبه لي ما كانش واضح قوي، لان انا كنت شايفه ان هم المفروض يحطوا level of significance between the two groups. بلس ان هم بداوا هنا يعملوا analysis للبيشنتس الاكشوال نمبر اوف بيشنتس اللي كانت الميجرمنتس بتاعتهم كلهم موجوده، فبداوا يشيلوا some patients، فالدنيا متلخبطه. يعني اللي هيبص على الجدول ده هيحس ان هو ملخبط شويه وهياخد وقت طويل عشان يفهمه، بلس ان هو لازم يرجع تاني عشان يشوف مين كان significant ومين ما كانش. فاي بليف ان هم كانوا ممكن يحسنوا الجدول ده شويه، ان هم لو حطوا level of significance كان هيبقى self explanatory احسن. بالنسبه للانهبيشن اوف ذا immune response we defined it زي ما قلنا ان هما دي الجراف ده مبين قوي. المفروض الخط الاسود ده المين الجيومتريك مين انتي بايوتيك فور بلاسيبو، والاحمر ده فور فينجيليمود. و at different time point this is pre-vaccination و 3 weeks و 6 weeks. كانوا بياخدوا الريشيو ما بين الفينجيليمود at any time point عند الثلاث اسابيع وعند 6 اسابيع، ويطرحوا الريشيو 1 accordingly they calculate the effect of fingerlimod on the inhibition of the immune response. فلقوا ان الريزلتس بتاعتهم ان الريشيو for the California strain was 0.59 and for the Perth strain was 0.56, and this was translated into inhibition of 41% for the California strain and 44% for the Brisbane strain. لقوا كمان بالنسبه للتيتانوس توكسويد نفس الكلام، كان translated into 35% inhibition at 3 weeks, and at 6 weeks the percent of inhibition was 38% for the California strain and 48% for the Brisbane strain and 27% for the tetanus booster dose. الريزلتس I believe ان هي كانت واضحه جدا في البيبر except for موضوع التيبل اللي كان ممكن يتعرض بشكل احسن. بالنسبه للدسكشن actually they started again by highlighting the main finding, و I quote the study ان هما they stated that the key finding of the study that fingerlimod treated patients with MS can generally produce an immune response against the influenza vaccine as a novel antigen and tetanus toxoid booster dose. However, clearly this response is much lower compared to placebo patients. بعد كده started to justify the findings. I quote them again, there was a clearly reduced immune response for fingerlimod treated patients as compared to placebo against two strains, California والبريسبان. وزي ما قلنا for the birth strain, the third strain اللي كانت موجودة في الفاكسين, they could not evaluate immune response ليها لأن already the patients كانوا بادئين ب high antibody titer even before vaccination. This resulted in a non-significant difference between the fingerlimod and the placebo treated patients. بالإضافة إن هم لقوا إن immune response was not evoked as strongly as anticipated even in the placebo patients, ورجعوا إن majority of patients عند baseline for the birth strain as well as for the other strains كان already عندهم antibody titer عالي، وإن 2/3 of the patients was already seropositive to California and Brisbane strain. فده ادى chance بس ل 30% من البيشنتس ان هم يconvert من seronegative ل seropositive. they summarized the rest of the results. وبعد كده بدأوا يدiscuss the previous literature. وده طبعا is a very important part من الدiscussion ان هو لازم يهايلايت اللي كان قال في previous studies ويهايلايت كمان why the other studies are different. ليه كان في نتائج قبل كده. هو actually هم they quoted او they cited two studies. واحده كانت showing more or less the same results والثانيه كانت فيها no difference between the finger remote treated and the non-finger remote treated patient, the placebo treated patients. بس هم قالوا ان this was most probably because of the use of different assays for measuring the antibody level. I believe the previous study used ELISA. مهم قوي بقى limitation دي has to be mentioned by the authors نفسهم. واي study مهما كانت even though this is a randomized control study but still it has its own limitation واحنا قلنا جزء منهم واحنا بنكومنت على بقيه ال sections of the paper. اول حاجه هم قالوا the antibody titers were not determined beyond 6 weeks after vaccination. مش عارفين ايه اللي بيحصل بعد 6 اسابيع بس دي كانت limitation. بس هم شرحوا في الاول هم ليه خلوا ال study duration 6 weeks لان هو ethically they couldn't have done it any longer عشان ما ينفعش كل ده يبقى ال patients eligible for treatment and they're not on treatment. Another limitation they did not correlate يعني هم كانوا شايفين ان هم they could have correlate كمان ال vaccine specific T cell response مع ال humoral immunity اللي هي represented في ال antibody level. طبعا they concluded at the end the result of the study provide class 1 evidence because it's a randomized controlled trial that fingolimod treated patient can mount an effective immune response after vaccination with both novel and recall antigen, but this response is generally and markedly reduced in some patients compared with placebo, and this should be taken into consideration when vaccinating the patient. And thank you, and I hope if anyone has any comments, I'm so happy to listen.
شكرا سارة. excellent presentation صراحة. أنا بس النقطة عايز أسأل عليها الحكاية إزاي حصلوا على الإيثيكال كوميتي أبروفال في إن هو يقعد عيان 6 أسابيع من غير تريتمنت.
بحاول أفتح السكرين.
ألو؟
ايوه يا دكتور هم they said ان هو they obtained the ethical committee approval من all the centers all the centers that participated وهم they justified الكلام ده بان هو they limited the study duration to 3 weeks. بس انا الحقيقه ما عنديش فكره هم ازاي عملوا كده.
يعني ازاي ثانيه واحده بس اقفل. يعني هم ازاي اخذ ابروفال يعني هل ده ايثيكال يمشي؟
هم they mentioned ان هي the short duration يعني kind of
4 اسابيع مش كده؟
لا 12 اسبوع 3 شهور
12 اسبوع يعني العيان indicated for DMT وما خدش لمده 12 اسبوع.
Yes, he's a well-known MS patient وما خدش treatment. They were on placebo.
طب وهل الفينجلومود كان الاسكليشن ولا الفيرست لاين؟
لا they did not mention this. They did not mention يعني that was not mentioned in the paper.
تهيألي ده كان should be mentioned يعني هل ده كان بالنسبه لهم يعني العينين دول مش
بس ثواني هم قالوا في الاكسكلوجن كرايتيريا لو في previous immune suppressive treatment was an exclusion. ف I believe يعني عشان يعني biologic ان هو غالبا كان the first choice يعني first treatment the patients received.
لا ممكن يكون اخذ انترفيرون ما بيعتبروش immune suppressant يعتبروه immune modulator.
هما they did not mention this clearly بس يعني أنا biologic I assumed كده بس هما اللي قالوه في exclusion criteria إن هو previous immunosuppressive treatment and they did mention whether the patients were escalated ولا this was the first line.
هو طبعا احنا دايما لما نيجي نحكم على بتاع ده على بيبر بيبقى في مشكله عندنا لما معكش حد بايو ستاتستكس يعني لان احنا طبعا الستاتستكس هنا يعني ايه معقده جدا ان احنا نقدر تيفالويت هل ده فعلا ماشيه ولا مش ماشيه ولا فكان في عندي واحد صاحبي كان يعني ايام ما كنا في امريكا كان هو بايو ستاتستيشن يعني وبيشتغل بعد كده في الشركات بتاعت اللي هي بتعمل ستاديز دي لشركات ادويه كان بيقول لي يعني انا اي حاجه عايزني اطلعها لك ممكن اطلعها. اديني
هو
اي
الفكرة
داتا وقول لي
هو
عايز منها كذا، انا هطلع لك الداتا دي ومحدش هيقدر يقول يمشي ويمسك ورايا اي حاجه في الداتا. فالبايوستاتستيشن يعني فظاع، يعني زي ما بيقولوا كده، يعني اذا كانش حد بايوستاتستيشن يراجع على واحد عمل بايوستاتستكس، صعب جدا ان كلينيشن يقدر يمسك عليها حاجه.
لا، وكمان الداتا نفسها انا حاولت ان انا اريتريف الداتا، بس it was provided in زي supplementary files و I couldn't reach it الصراحه. يعني انا كنت عايزه اشوف the raw data بقى والجداول كلها، بس ما عرفتش اوصل لها لانها كانت provided elsewhere.
اه
believe ان هو for adequate criticism لازم يبقى في حد طبعا definitely. يعني مهما حاولنا نجتهد يعني مش هنبقى
طبعا
efficient طبعا.
خاصة ما يخش بقى في الستاتستكس العميقة قوي بقى، طبعا بتبقى
لا،
يعني
وهما مثلا الميجرز كمان كان في ميجرز، يعني الجيومتريك مين انتي بودي تايتر، يعني
بالظبط
اصلا
كده،
قعدت
حاجات
كتير
يقول
عشان
لك
افهم هو ايه ده يعني وليه. طيب يعني ليه مش المين بس؟ فدي برضو حاجه انا يعني ما قدرتش افهمها، يعني الفكره من الحسبه دي.
في حد عنده اي تعليق؟ اسماعيل لو نام، اسماعيل نام ولا صاحي؟ هو موجود بس مش عارف نايم ولا صاحي. اي حد عنده؟
صح يا باشا صح.
انا عارف انت بتنام. لا ده السكند ويند بتاعك، ماشي.
لا لا بس ما عنديش كومنت الحقيقه على الموضوع ده لغايه دلوقتي.
يعني بس برضك ستيل برضك انا زي ما انت قلت كده، انك انت تقول ناخد من الداتا دي اتعملت في امريكا وتحطها تابلايت في مصر، او تابلايت في حته تانية، مش فيزياء. صعب جدا.
صعب جدا انا شايف، خصوصا اي ثينك كمان ان في امريكا different races يعني حتى even I don't think ان هم they never. نعم
مش
اتفضل.
يعني كانوا اخذين
I don't think حتى هم البارتيسيبنتس بتاعت الستاديز ديت هل هم they identify ال kind of race بتاعهم ولا لا، يعني ما اعرفش. هشام يمكن يقدر يعمل لنا كومنت على الموضوع ده، لما بيبقى حاجه زي كده وفيها racial differences هل بتبقوا عارفين الديتيلز بتاعه الريسز بتاعه الناس اللي داخلين في الاستاديز، ولا ما بتفرقش خالص، ولا ايه؟ I don't know الحقيقه.
حازم دخل.
هو يعني نقطة مهمة طبعا دكتور اسماعيل. دكتور حازم. النقطة اللي هي بتاعت تمام الحمد لله. النقطة بتاعت الريس طبعا نقطة مهمة جدا و very valid بصراحة. I think I have two comments عن الموضوع ده. The first comment إن هو randomized control trials for the new medications, new disease modifying therapy, whether for MS or other neurological conditions, they started including vaccination as part of the trial. So you're already studying a new medication versus an established medication. And one of the secondary outcomes is the response to vaccine. And this helps because the big randomized control trials اللي هي therapeutic, يعني it is more likely to involve countries like Egypt أو Eastern Europe أو يعني اللي هي developing countries. They do participate في اللي هي huge clinical trials اللي هي بتبقى محتاجة 2,000 participants. So having the vaccine as a secondary outcome or response to the vaccine as a secondary outcome during those therapeutic clinical trials helps. لأن هيبقى فيه more representation. يعني لسه Inebilizumab anti-CD19 monoclonal antibody in neuromyelitis optica clinical trial just got published recently. This trial, international trial, يعني Eastern European countries were included and so forth. كان جزء من الترايل a response to vaccine, not as a primary outcome but as a secondary outcome, which helps شوية في generalizability of this data. The second question about مثلا in the US-based clinical trials about the race, دي نقطة مهمة جدا. ويعني there is actually في معظم الأمريكان institutions وفي new clinical trials there is a need for more inclusion, يعني more involvement of the African American race, for example, which is underrepresented طبعا in most of the clinical trials. لدرجه ان مثلا في open label trial حاليا ocrelizumab is doing it anti-CD20 monoclonal antibody in MS is just in the African American population. So they are doing clinical trials recruiting only minorities in order to get better insight to the effect of those medications in the African American race or non-white race in general. So it is a problem. It is recognized as a problem. And currently there are some forward steps trying to overcome this problem. That's a very valid point. And للأسف الساينس اللي بنتعلمه حاليا mainly based on Western European and American white race population with very little inclusion of Hispanics or African Americans or Middle Eastern. Asian is becoming a little bit better involvement in clinical trials, but you're absolutely right. The majority is based on those Western European and American white population whose genetic background is completely different from the genetic background of someone who's Egyptian or Indian or so forth. Like, the first step is recognizing that there is a problem. Exactly. The first step is recognizing that there is a problem, and it is recognized, and there is some forward steps now to overcome this, which is something hopefully we'll start seeing in the next 5 or to 10 years in the new clinical trials that are coming in the field, hopefully.
اوكي عشان الوقت ننقل هشام بقى على مسك الختام. هشام هياخد بقى اللي هي الجايد لاينز اللي هي لما بقى كل الحاجات دي اللي هي بتاعت 2019 الامريكان اكاديمي جايد لاينز اللي هي المفروض لمت بقى كل الايفيدنس لغايه كان السنه اللي فاتت يعني. شير يا هشام.
متشكر جدا، متشكر دكتور اشرف، متشكر لجميع الحضور، وانا سعيد جدا جدا بالدعوه دي. حاجه يعني الهايلايت اوف ماي مانث ان انا اشوف اساتذتي وزملائي في مصر، ويعني the silver lining زي ما بيقولوا للكورونا فيروس، الموضوع ال virtual meetings and how we can all get a little bit closer. I think this is at least one advantage of this unfortunate situation. You guys can see the presentation very well. Not sure if you can see the presentation.
بس خلينا نعمل سلايد شو بس عشان ان هي مش سلايد شو دلوقتي. اوكي كده. لا برضك ستيل
يعني
ماشي، ما باينه يعني، ما فيش مشكله لو انت مش عارف تعملها. اوكي
تمام. وطبعا برضه احب اشكر جدا ايمان وساره على الاكسلنت برزنتيشنز. طبعا احنا عندنا الجورنال كلاب بيعملوه ريزيدنس، فبيبقى المستوى مش عالي للدرجه دي. they did an excellent job صراحه، and يعني very very thorough and very detailed examination. طيب my presentation هي paper from the Neurology Journal برضه. So the 3 papers are from the Neurology Journal. This paper came out in 2019, Practice Guidelines Update Summary, Vaccine Preventable Infections and Immunization in Multiple Sclerosis. This is one of a series of publications that the American Academy of Neurology produces and develops periodically to examine treatment guidelines in general in neurology. This is a specific subcommittee in the American Academy of Neurology called the Guideline Development, Dissemination, and Implementation Subcommittee of the American Academy of Neurology. They have multiple papers that develop. Every paper is assigned to a specific group of experts who are experts in that field. Last year, also 2 years ago, I think they presented the Guideline Development, Dissemination, Implementation Subcommittee for a report for the disease-modifying therapy use in MS, which was also a very important paper in the field. We actually did a journal club on this same article in our program last year. So I basically just stole the presentation from the resident. So I apologize if the presentation is a little bit disorganized, but it's better than reinventing the wheel, as they say. So the background the American Academy of Neurology published a paper in 2002, immunization MS, and this current paper is supposed to be an update of this previously published paper, including new evidence, new papers, new vaccines, and the addition of new disease-modifying therapies that have been available since that time. The recommendations are based on evidence, so they did a systematic review of literature, which we'll go through in the next slides, and then they also performed meta-analysis if there was more than one study addressing the same question. But they also included related evidence, like from other conditions that use this same or similar disease-modifying therapies. Also principles of care, whatever the FDA specified in the package insert of the medications, and even inferences, or basically making logical judgment by putting the evidence into context. So basically, not every recommendation in this paper is based on the reviewed evidence. Some of the recommendations have other bases, which is something we will discuss also among the limitation of the paper. So the paper tried to answer a set of specific questions. Question number one was, are vaccine preventable infections more frequent in patients with MS than the general population? Question number two, do vaccine preventable diseases increase the risk of developing MS or triggering MS relapses? Question number three, does vaccination increase the risk of developing MS or MS exacerbation? And then are vaccines as effective in MS in general? And how about their efficacy in patients taking disease-modifying therapy? Is the efficacy of the vaccine diminished or reduced because of the disease-modifying therapy on board? Well, I think question number five is the most important question because it is relevant to the COVID-19 pandemic. Once the vaccine comes out, we will all have to make those decisions. Can the patient take the vaccine? Is the vaccine going to be effective in this patient or not? And that's why I think the question number five is the most important question, and I will try to focus on this question during the presentation. So this is the hierarchy that Dr. Iman also presented in her presentation. We can see that the lowest or the weakest scientific evidence comes from case reports, expert opinion, letters, and even consensus papers. So, a lot of consensus papers are very highly cited. A few consensus papers are cited 2,000 times in literature. But at the end of the day, those are just consensus, meaning they're a group of experts sat together in a room and they decided this is what it is. So this is, although highly cited in medical literature, most consensus papers are actually low scientific evidence. And then followed by animal trials, cross-sectional studies, case control studies, which could be retrospective, prospective cohort studies, and then, of course, the highest is randomized controlled trials, inferior only to meta-analysis and systematic reviews, as long as they were well designed. And our paper here belongs to the top here because it's a systematic review with at least partial meta-analysis for some of these questions. So the analytical process, they had the inclusion criteria that they predefined was evaluating randomized controlled trials, prospective cohort studies, and case control studies that were published between 1990 and 2018. The minimum sample size for any of the study to be included had to be 10 patients at a minimum. They excluded any case reports or case series, even if the case series was higher than 10 patients, but it was not controlled, there was no control group, then this was excluded from the systematic review. And then the papers that made it to the actual grading of the quality of evidence were actually rated by two reviewers. So each paper was rated by two separate reviewers in order to get some consensus or agreement between the two. Of course, if there was any disagreement, that means that additional review is required. So this is how they started. So they did several time points where they looked at they did the literature search. They did one in 2012, one in 2015, 2016, 2017, and 2018. And of course, the point of doing this is to try to always get the most recent papers prior to the time of actually writing the full manuscript. So this is a point of this yielded 4,560 abstracts that they had to review. By reviewing the abstracts only, they were able to exclude 3,877 abstracts that did not meet criteria, so they didn't even need to go into the full text. Just by reviewing the abstract, those were excluded. And this led to 683 full text articles that they reviewed. After they went in and reviewed the full text article, 535 were excluded, still did not meet the criteria they predefined. And this led to 148 papers that actually went to reviewers for actual grading of the scientific evidence. When they looked at the actual grading, they still had to exclude 96 papers. And this left us with 52 papers that they actually basically constituted the base of some of the recommendation in this paper. And this just gives you an idea of how hard it is to do a systematic review, especially on a topic that is that common, vaccination, multiple sclerosis, which is a relatively common condition, especially in the Western world. They had to start from 4,000 papers and then ended up with 52 papers. That's why systematic reviews, although seemingly they look easy because you don't need IRB, you don't need to do an actual clinical trial, you don't need even funding most of the time, except for the time spent on doing the study. But it's actually a very hard job because you need an army of people to go through all these abstracts and full text articles. So since we're talking about the level of evidence, we have to talk about what the American Academy of Neurology, the methodology they use to classify the evidence. It's not very different from what other organizations and institutions use. And if you compare this to the slide in Dr. Iman's presentation, it's very similar, but not identical. So the American Academy of Neurology has their own manual and definition of level of evidence. For class 1 evidence for interventional studies, this has to be a randomized controlled clinical trial of the intervention of interest with masked or objective outcome assessment, meaning that the raters have to either be blinded or the outcome is something that is completely objective, like antibody level in the blood, for example. So you cannot really bias that. And then in addition to this, the baseline characteristics between the studied group and the control group have to be matched or very similar. And in addition, there must be blinding or concealed allocation. The primary outcome is clearly defined. The exclusion-inclusion criteria are clearly defined. And a sufficient number of patients completed the study, meaning that the dropout was minor, or if it was not minor, it was accounted for statistically in order not to confound the results. Class 2, it's either a randomized controlled trial that lacks one of those criteria that we just mentioned. Maybe the exclusion criteria were not very well defined or the dropout rate was high, but as long as it was only missing one of those criteria, then this qualifies for a class 2. More commonly, class 2 studies are actually prospective cohort studies that are well designed with either objective measurement or sufficient blinding. Class 3 studies, those include case control studies, including retrospective studies, as long as well designed and still the outcome is objective, not subjective. Anything else is considered class 4, whether it's a case report, case series, opinion, even consensus paper. All these are considered class 4. Pay attention also that any patient-reported outcome is actually considered class 4. So there's a lot of movement now towards we want patient-reported outcomes, what the patient actually is interested in. So we don't care if the antibody level is so forth or the MRI is better. We care about what the patient reported. Do I feel better? Do I feel stable? Although this is important for patients and very important clinically, from the scientific evidence standpoint, because this is a subjective outcome that can be easily biased, is actually not considered higher than class 4 evidence, even if the study was otherwise well designed. Now, translating the class into recommendations. So once they look at the class of evidence, they translate this into recommendations for clinicians and the neurology community. The highest level of recommendation is level A, and level A recommendation requires at least 2 consistent class 1 studies, meaning that the class 1 studies actually agreed in their results. So for example, if one study showed that fingolimod reduced the protective immune response to the vaccine of influenza vaccine, the other one has to also have the same result. If they were both well designed but contradictory, then this, of course, cannot translate into a level A recommendation. Level B requires at least one class 1 study and or 2 consistent class 2 studies. So two class 2 or 1 class 1. Level C requires at least 1 class 2 or 2 consistent class 3 studies. And then level U, basically anything less than 2 consistent class 3 studies. So if it was 1 class 3 or any class 4, or there's a lot of studies that are contradictory and conflicting, then this is level U, meaning you cannot really make any recommendation. There's insufficient data to make a recommendation. When translating this into easily understandable sentences for clinicians, a level A recommendation means that this effect is established. So you'll say physicians must. So physicians must, for example, check the blood level after vaccination in patients taking fingolimod, because there's enough evidence that fingolimod reduces the autobody, the immunoprotective response to the vaccine. So this is worded as physicians must, the highest level of recommendation. Level B, that means that this intervention is probably effective or harmful. And here they word it as physicians should. Level C, the evidence here is not as strong, so they word it as physicians may. And then if it's level U, so basically there's insufficient evidence to support or refute. Now, having insufficient evidence doesn't mean that this is a negative relation. So for example, when we talk about the effect of influenza vaccine on MS relapses, there's really insufficient evidence to suggest that influenza vaccine can trigger MS relapses. That doesn't mean that influenza vaccine does not trigger MS relapses. It just means that we do not have sufficient evidence to support or refuse that the influenza vaccine can cause or trigger MS relapses. So this has to be understood this way, and this is a mistake in this paper actually, and we'll talk about the limitation towards the end, that having insufficient evidence doesn't mean there's no relation. So we have to be very, very careful. It just means that maybe the studies need to be refined, or better studies or more studies need to be done in order to answer this question. So if we apply the AN class of evidence to the 2 articles that we just discussed, and I think Iman and Sarah already did this, and they did an excellent job. But basically, when you look at the study of the interferon beta 1A and the influenza vaccine, it was a prospective cohort study, but it wasn't randomized. You know, patients who took sorry about that. Basically it was not randomized study. So patients who took interferon beta 1A, there was a reason for this. It wasn't really computer-generated randomization. And patients who did not take it there was a reason for that. And it was also open label. So people, of course, who took interferon knew that they weren't interferon. People who were on placebo, they knew that they were on placebo. And then the actual outcome was objective because it was a blood test. It was a representative population, was controlled and matched. So there was a control group, and the baseline characteristics were matched between the 2 groups. There was clear inclusion-exclusion. There was no dropouts at all in the study. So that means that this is a class 2 study. It was a very good prospective cohort study, but it wasn't randomized and it wasn't blinded. So this is why it's not a class 1. While the fingolimod study that Sarah presented was a blinded, randomized, multi-center, placebo-controlled study. There was an objective outcome. It was a representative population, controlled and matched, with very clear definition of the outcome and inclusion-exclusion criteria. And there was only minor dropouts that did not affect the statistical power of the study. And that's why it was considered a class 1 study. Now, I'm going to go a little bit fast with those because this is really not the most important parts of this paper, really, or at least not as relevant to the whole COVID-19 situation that is going on currently. But one of the questions was, is a history of vaccine-preventable disease more frequent in patients with MS? And the bottom line here that there was no data, no sufficient data to suggest that any of those vaccine-preventable diseases that they tested or that there were literature on are linked to more frequent MS prevalence. However, people who had hepatitis B were actually less likely, who had the history of hepatitis B, were less likely to have a diagnosis of MS. But the level of evidence was low, but it was there. So maybe hepatitis B might have a protective role against development of MS, but clearly more studies is needed for this conclusion. Second question, do vaccine-preventable infectious diseases increase the risk of MS relapses? So that's an important question because one of the justifications when we say well, maybe we should recommend vaccination to MS patients is because the triggering MS relapses, if they catch the infection, is probably higher than the risk of actually catching it from the vaccination itself. So this is why it's justifiable. Well, when you actually look at the data, there's really no evidence that any of the vaccine-preventable diseases increase the risk of MS relapses or trigger MS relapses, including influenza. So even influenza, here in the United States, we get this question every fall or early winter: should I take the influenza vaccine? Well, we do not have sufficient data to suggest that catching influenza will trigger your MS. We do not have this data. That doesn't mean it does not trigger MS relapses. We just don't know. All right. So النقطة اللي دكتور إبراهيم برضو he mentioned it. Yes, we know that infections can trigger MS relapses, but not really vaccine-preventable infections, just common infections, right? Common cold, these things, probably they can trigger MS relapses. We see it all the time, even UTIs, bacterial infections. But when looking specifically at the infections that you can prevent by giving a vaccine, there's really no data to suggest that MS relapses can be triggered by those types of vaccines. The closest thing to evidence was only in varicella zoster virus. There was one study that showed that the DNA or PCR of VZV in the serum of patients who have MS was higher in those who are having relapses compared to those who are in remission, and none in patients with healthy controls who do not have MS. We don't know what to do with this, so the actual clinical implication of this finding is unknown. But one thing you should consider as a clinician is, because a lot of our newer disease-modifying therapies do increase the risk of herpetic infections and varicella infections in general, should we check the varicella zoster virus antibody on every patient before we put them on disease-modifying therapy? And if they don't have the antibody, meaning they are not protected, they didn't have chickenpox when they're younger, they never received the vaccine, should we consider vaccinating them before we put them on the disease-modifying therapy, especially that the vaccine is a live vaccine? So if you put the patient, for example, on fingolimod or something like that, you cannot actually give them the vaccine afterwards, as we will see in the next slides. How about, so this was the vaccine preventable infections. Now we're talking about the vaccine itself. Does vaccination increase the risk of developing MS? And bottom line is actually looking at the studies, some vaccines are actually probably protective. So HPV, human papilloma virus, which is a vaccine that is commonly offered to sexually active females here in the United States, and there's growing evidence that you can even offer it to males as well. So people who actually received the HPV vaccine, at least in 2 studies, had a lower likelihood of developing MS in the future. And this was based on 1 class 1 and 1 class 2 studies. For pertussis, same thing, again, based on 2 class 2 studies. If you receive this vaccine, you might have a lower risk of developing MS in the future. So this is good news here, but again, it's only for these 2 vaccines that maybe there's a lower likelihood. Similar is for tetanus toxoid as well. This one was based on 4 class 2 studies. For the BCG vaccine, there was insufficient evidence to link it to MS in general, but there was one class 1 study that showed that if you have clinically isolated syndrome and you had received the BCG vaccine in the past, you're less likely to develop to evolve into full-blown MS in the future. So for the question about vaccine and developing MS in general, looks like most of the studied vaccines were actually protective against developing MS. Now, this is actually the most important question. And what about the effect of vaccines on MS relapses? So you already have MS, you're already maybe on disease-modifying therapy, and then you're asking, should I get the flu vaccine? Which is actually the most important question. And this is the question that will come when COVID-19 vaccine becomes available. Should I take the vaccine, or could it actually trigger an MS relapse, or could it cause COVID-19 infection if I take it because I'm on disease-modifying therapy, which is question number 5. So for the question about the relation between the vaccine itself and triggering an MS relapse, there was really no sufficient data to support or refuse that vaccines of any kind of the ones studied can actually trigger relapse, including influenza vaccines. So keep in mind that, you know, the AN here at the end of the paper make a very strong recommendation towards, in support of influenza vaccine, although we really have no sufficient data to suggest that influenza triggers MS relapses, and we do not have any sufficient data to support that influenza vaccine protects or triggers MS relapses. So this was a strong recommendation, but it wasn't based really on the evidence that they reviewed, and this is really one of the major limitation of this study, of this paper. Now, another question, are vaccines effective in MS patients in general? So this is regardless of disease-modifying therapy status. If you have MS, are vaccines going to be effective in your particular situation? And they looked at a number of vaccines. This is just an overview of what vaccines are live attenuated and which ones are inactivated or killed and which ones are toxoids. Of course, diphtheria and tetanus are toxoids. Most of the influenza vaccines that are available commercially that are commonly offered to patients in the US and I believe worldwide is a killed influenza vaccine that is given as an injection. Of course, the hepatitis B is also a common question because of healthcare workers are required to take hepatitis B vaccine. So that always comes. That's a killed or inactivated vaccine. Same for meningitis for patients who college students and military who are required to take the meningitis vaccine. Those are all non-live vaccines, so keep that in mind. There is a live influenza vaccine. This is the intranasal vaccine that you take it as a nasal inhalation. Not very commonly used, but every now and then this question comes. So keep in mind that the nasal influenza vaccine is a live vaccine, which have implications to some of the disease-modifying therapy. And of course, the same for MMR, and the varicella chickenpox vaccine is a live vaccine as well. So first, the two halves for the question. The first half is, are live attenuated vaccines as effective in MS patients? They identified 0 studies. So basically no one is brave enough to give an MS patient a live vaccine, looks like. So there's really 0 studies of that. I guess with fingolimod, because the varicella zoster vaccine is mandatory, I think Novartis might have some future data on this, basically the immune response. In clinical practice, before we put a patient on fingolimod, we always test, and if they are negative, we give them the varicella vaccine. And in my experience, every single patient mounts a protective immune response against the vaccine. So it looks like, at least anecdotally, MS patients who are non-disease-modifying therapy can mount a response to a live vaccine as represented by the varicella zoster. How about inactivated or killed vaccines? There was 3 class 3 studies that showed that MS patients have a higher likelihood of an insufficient response to an influenza vaccination. And the details of whether those patients were on disease-modifying therapies or not were not clear from the paper. I probably should have tried to do some digging and go back and try to find out, but I actually did not do that, so I apologize. But in general, those 3 class 3 studies suggested that if you have MS, regardless of the disease-modifying therapy status, you might already have a reduced response to a killed vaccine like the influenza vaccine. And now, with the most important question is, does treatment of MS, disease-modifying therapy, does it reduce effectiveness of vaccination? So, of course, here they looked at specific DMTs. One was influenza vaccine and interferon beta, which is, what Dr. Iman presented earlier in the Journal Club. And what they found based on 2+1 studies, including, so 2+1 studies actually, and then 3 class 2, including the study that Iman presented, and 1 class 3 study, that interferons in general do not have a meaningful reduction in the likelihood of seroprotection, meaning that once you get the influenza vaccine, if you are on interferons, you're expected to have a protective response like someone who is not on interferons. So this is a safe disease-modifying therapy in that regard. And this is great news. And this was based on a number of studies. All of them were kind of high class studies. So this is very reassuring to the MS community. The second was influenza vaccine in glatiramer acetate. So again, this is a medication or disease-modifying therapy that we generally look at as a disease-modifying therapy, very safe disease-modifying therapy. But there was actually some studies that showed that patients on glatiramer acetate have a reduced likelihood of seroprotection after influenza vaccine. And this was based on 1 class 1 study that was a little bit imprecise based on what the paper reported, and 1 class 2 studies. There's a lot of criticism to this in the scientific community now, because we're talking about COVID vaccines, and when we have meetings and things like that, most experts believe that glatiramer acetate is safe and should not have a negative effect. But actually, in the American guidelines and based on their studies, it might have a negative impact on inactivated or killed vaccines. Influenza and fingolimod. This is like the paper that Sarah presented earlier. It is probable that individuals who are on fingolimod will have a reduced likelihood of seroprotection, and this was based on 2+1 studies. One of them was imprecise, and one of those studies is the study that Sarah presented. Not that they cannot mount a response; they can mount a response, but it's less compared to people who are not taking fingolimod. Meaning that maybe if the COVID-19 vaccine becomes available, people on fingolimod can take it as long as it's not a live attenuated or live or viral vector vaccine. They can still take it, but you might want, as a clinician, you might want to check the serology after the vaccination to make sure that the patient actually mounted an immune response to the vaccine before they start going out and reduce social distancing and so forth. How about natalizumab, influenza vaccine, and the same for teriflunomide? There was basically no sufficient data to suggest whether it's, there will be a reduced immune protective response after vaccination in those patients or not. Although I am aware of one study in natalizumab that showed that there's no negative impact. I think it came after the publication of those guidelines. And then we come to the actual recommendations. So they made those recommendations. So for example, here, the first few recommendations are just general recommendations here. Number 1, clinicians should discuss the evidence from this systemic review with their MS patients about immunization and MS. So this is a level B, so should. So you see when it's level B, they say should, not must. Of course, it's very important in the current time to discuss vaccination because of the whole COVID-19 situation. So it's a good practice for the clinician to be proactive and to talk to the patient about vaccination at the time of diagnosis and initial evaluation, first or second visit, basically. Number 1B, clinicians should explore patients' opinions and preferences. So this is kind of a very American part of the recommendation. It's because, there's a amendment against vaccination currently in the United States. And, because of the people's rights and freedom, you have to always consider, the and they say, well, we're not interested in vaccination anyway, so I don't need this conversation. Of course, the caveat to this is COVID-19 vaccination might become mandatory in certain parts of the world. So this will add another complexity, of course, to this recommendation here. Third recommendation, clinicians should recommend that patients with MS follow all local vaccine standards. Of course, if there's anything that is mandated by the government, unless you have a very specific contraindication, you should follow the guidelines. Again, also the same for the local guidelines. And then, this one is the one that I have a problem with when they state that clinicians should recommend that patients with MS receive the influenza vaccination annually unless there's a specific contraindication. And they actually put this as a level B. So level B, you're supposed to be backed up by either one class 1 study or 2 class 2 studies. And basically we have none of that. It was all class U. So this was a very strong recommendation that was really not backed by any data at all, and kind of a contradictory there. And I think is actually the major limitation of this paper is this specific recommendation here, because this is the most important question, most common question that we get every year: should they take the flu vaccine or not? And we're making a level B recommendation that is really not backed up by any science at all. Recommendation number 5, clinicians should counsel patients about the infection risk associated with specific disease-modifying therapy. This is, of course, goes without saying that if the package insert has certain infection risk, we have to talk to the patient about that. For example, varicella and herpetic disseminated infections in patients before starting fingolimod, or hepatitis B before starting ocrelizumab, and so forth. You should assess or reassess vaccination status before prescribing disease-modifying therapy. So before you start fingolimod, you should actually check the varicella zoster immunoglobulin G level to make sure that this patient is protected. And if they are not protected, you should vaccinate them and then allow time 4 to 6 weeks before you actually give them fingolimod from the time of the second booster dose of the vaccine. This is an important recommendation, 5C, you should discuss vaccination as early as possible. So even if the patient is not considering treatment, because now here in the United States, the decision about starting disease-modifying therapy and the selection of disease-modifying therapy is mainly made by the patient. So as a clinician, you just offer all the options to the patient. You might make a recommendation towards one medication or 2 medications or so forth, but the final decision is to the patient. So even if the patient is deciding not to start treatment against your medical advice, you still have to talk to them about vaccination, because you want to have your patient vaccinated against, let's say, varicella zoster, for example, as early as possible. So in case you need to start this patient disease-modifying therapy, or the patient decides to start disease-modifying therapy, you don't have to wait for the 4 to 6 weeks window before you actually can start disease-modifying therapy. So if you're going to vaccinate as early as possible. The odds are, if the patient is already refusing disease-modifying therapy, it will be the type of patient that will refuse vaccination as well. Now, recommendation number 6, clinicians must screen for certain infections according to the prescribing information. So some medications in the package insert, they will say you have to rule out tuberculosis, for example, like in teriflunomide. You have to rule out lack of VZV immunity, like in fingolimod. You have to rule out hepatitis B, as in ocrelizumab. So this goes without saying. It's the package insert. They give this a level A recommendation. Again, this is really not backed by any studies. It was just based on the FDA recommendation and the package insert. Everyone will follow this because it's FDA recommendation, but it wasn't really supported by any data that you need to do that. It just goes by common sense. That's a point of strength and a point of weakness at the same time. Point of strength is common sense is common sense. You do not have to prove every little thing in science, but also a point of weakness because they call it level A, although it didn't really meet the criteria for a level A recommendation based on what they put in their manual. And then recommendation 6. So in high-risk population in certain countries, you might want to check for certain endemic chronic infections, even if it was not in the package insert. So for example, in ocrelizumab, it doesn't say that you have to check for hepatitis C, but in a country like Egypt where hepatitis C is endemic, it makes sense that you actually check and make sure that there's dormant infection, to at least get a consultation from a hepatologist before you start the treatment. So this is also kind of a recommendation that allows variability of practice and takes in consideration practical issues that differ from one country to another. And then clinicians should recommend against using live attenuated vaccines in people with MS who currently receive disease-modifying therapy or have recently discontinued those therapies. And this is level B recommendation. Again, there is some limitation to this sentence, which we will discuss in the next slides as well. And then this one, number 7, is actually very interesting, and I actually wasn't aware of this recommendation until I prepared this particular journal club. They actually said when the risk of infection is high, clinicians may recommend using live attenuated vaccines if killed vaccines are unavailable for people with MS who are on disease-modifying therapy based on benefit versus risk ratio. And this might actually come up in the COVID-19 pandemic, because they are developing both inactive and live vaccines for COVID. What if the live vaccine is the one that actually passes safety and efficacy regulations and becomes the only vaccine available? What are we going to tell our MS patients? What if there is a second wave and patients are in a country with very heavy involvement and high severity and death rate? Then maybe we can even recommend giving the live attenuated vaccine, even if the patient was on disease-modifying therapy, in order to reduce their chances of getting bad infection. So although this is really not backed by science, but at least it's backed by the AAN guidelines that you can use in that sense when you start the conversation with the patient. And then recommendation number 8, and this is the last one, clinicians should delay vaccination of people of MS who are experiencing a relapse until clinical resolution or until relapse is no longer active, and they give this level B. And this is mainly really based on the fact that patients are getting steroids and, you know, giving them vaccination while on steroids. If it's a live vaccine, it's dangerous. If it's an inactivated vaccine, it might reduce the efficacy of the vaccine. But really there's no data as well. So again, level B recommendation is stronger than the available studies to support this recommendation. This is just an overview of the vaccine recommendation in the package insert, the FDA approved package inserts of some of the available disease-modifying therapies that we use on a daily basis. For fingolimod, in the package insert, they recommend avoiding live vaccines 1 month before starting treatment, during treatment, and for 2 months after stopping treatment. They also state that VZV vaccine is mandatory for non-immune individuals before starting treatment. So you have to give them the vaccine, wait for a month before you actually give them, put them on fingolimod. In teriflunomide, the package insert states to avoid live vaccine during treatment and for 6 months after stopping treatment. For ocrelizumab, avoid live vaccines 1 month before, during, and after treatment until B-cell repletion, meaning that even if you stop treatment, you have to keep checking the B-cell or the CD19 cell count in the blood, and only start vaccinating once the B-cells are repleted. And then if you have to give an inactivated vaccine in someone who is on ocrelizumab, then you have to check the immune response, meaning the vaccine might not be effective because ocrelizumab depletes your B cells, meaning the formation of antibody will be affected. So if you get the influenza vaccine or a killed COVID vaccine in the future, you can take it, it's safe, it's not a live vaccine, but you might not mount a protective response to the vaccine. So you as an MS clinician, it is your responsibility to check the antibody level after vaccinating the patient and making sure that the patient actually mounted the protective response before they ease down their social distancing and going back to the community. And then alemtuzumab, it says avoid live vaccine 6 weeks before, during, and after recent treatment. They did not specify the number of months. Cladribine was not included in the AAN guidelines because it received FDA approval in the United States after this paper came out. We all know that it was approved in Europe for a while, but it only received FDA approval actually earlier this year. The package insert of cladribine says to avoid live vaccines 4 to 6 weeks before and during treatment. And then they also say that VZV vaccine is recommended for non-immune individuals before starting treatment. Last few slides. So what are the strengths of the current guidelines? First of all, coming from the AAN, so this is always helpful when making a conversation. It's a very reputable organization, so you can use, well, the AAN says so and so, so at least it backs you up. If there's no sufficient scientific evidence, at least you have some guidelines that are coming from an organization of experts. They did a systematic approach, of course. They had very well inclusion-exclusion criteria. They included updated literature search at different time points. Definitely improved the publication compared to what was published in 2002. They did the meta-analysis when appropriate. Of course, the meta-analysis was based on each question separately. So if one question had more than one study that they can analyze together, they did that. If there was already meta-analysis for that question that is published, they used those data for their recommendation. The meta-analysis, as we discussed, is the highest level of scientific evidence. They had very clear clinical questions, very well divided, very well organized. They did classification of evidence. They excluded weak studies. Those are all points of strength. They did acknowledge that literature was really minimal in certain specific questions that they addressed, and that's why at least the majority of the recommendations were either level B or C, meaning they did not make any strong recommendation. They did make some strong recommendation, but most of the recommendations were modest, acknowledging that the level of evidence might either be modest or there's not enough literature to make strong recommendations. They also included a disclaimer in the paper at the end that those guidelines are voluntary and non-obligatory in nature, meaning that the physicians can still do whatever they think is clinically applicable to their patient and to their patient population specific situations. So it's just more of a guidance rather than obligatory protocols. And of course, it helps with patient conversation because, you know, the vaccine conversation, if you have a well-educated patient or an anti-vaxxer patient who doesn't believe in vaccine, the conversation can become really intense. So having a document like this in your hand, a paper that you can share with those patients to say, well, this is what the American Academy of Neurology recommends, it will definitely help make those conversations easier. And then the limitations, of course, there are some limitations that the, you know, Sarah and Iman mentioned in their presentations. When you do a journal club like this, first you present the limitations that the authors themselves acknowledged in the paper. And, you know, authors will always acknowledge some limitations, mainly because it is required by the reviewers. You cannot publish if you're not going to acknowledge limitations. But keep in mind that most authors will not really acknowledge all the limitations, and they will actually try to hide the strong limitations. So most of the limitations that are presented are usually the easy ones or the ones that you can turn into a strength, saying, oh, this was a limitation, but we did this to account for it or something like that. So for critical appraisal, as a reader of an article, you actually have to look for the limitations that were not mentioned by the authors, like Sarah and Iman did in their presentations as well. So really, one of the limitations they acknowledged is that, you know, when you publish something that was written in 2018, will probably be published in 2019. In the meantime, during the publication, there might be 20, 30 new publications that were not included that will come before the publication actually becomes available. So it might not reflect the most recent evidence. And then some limitations they did not acknowledge, that, you know, level A recommendations were really based on FDA approval and package insert information, but it wasn't backed by specific studies in MS population for that specific question. So although they worded as must as a level A, it wasn't really backed by the studies like they put in the manual of the AN itself. A lot of disease-modifying therapies were lumped together as one entity in the final recommendation, despite different mechanism of action and impact on vaccination. So for example, when they talk about live vaccines, they just say, for any patient on any disease-modifying therapy, you should not give live vaccine. Well, you shouldn't really treat all disease-modifying therapy as one. You know, you have something like interferons, like Dr. Ashraf mentioned. It's not really an immunosuppressant, it's an immunomodulator. It doesn't kill any of your immune cells. It has antiviral effects. So we don't really know if live vaccines are unsafe in those patients. We basically just don't know. There's no data. So you cannot put that recommendation like that, especially now. You know, we might have a live vaccine, and most patients are on interferons, especially like in Egypt and in maybe non-Western countries, most people are on interferons. We don't want them to be denied the vaccine based on absence of data, because you put a recommendation there that was not backed up by information, by scientific evidence. So lumping all disease modifying therapy is not a good idea. Interferons clearly, or glatramere acetate, is not as immunosuppressant as something like alemtuzumab that kills every lymphocyte and even innate immunity cell that you have in your body. So you cannot really lump them together. And this is one of the biggest weakness of this recommendation, is that it wasn't really disease modifying therapy specific when they made the final recommendation. The influenza vaccine recommendation, already touched on that, was really placed as level B despite lack of sufficient evidence to support or refute link to MS relapses. So no evidence should not be taken as definitive absent effect. So when you make a strong recommendation like this, actually, it is possible that influenza vaccine might trigger MS relapses. So when you don't have data, you shouldn't have put this as a recommendation level B. Just, you should say, we need more research on this, especially that this is really a very common situation. So again, I think they were a little bit unfortunate in the way they actually worded this in the final recommendation. Very important point, the effective lymphocyte count and immunoglobulin levels on vaccination was not addressed. We know that many of the disease-modifying therapies cause lymphopenia, either as part of the mechanism of action of the medication, like ocrelizumab causes selective B-cell lymphopenia, or alemtuzumab and cladribine in the lymphocyte depleting phase, they cause a generalized lymphopenia. So what's the effect of the lymphopenia on the vaccination? How about patients on dimethyl fumarate or droxamyl fumarate? Those patients, those medications do not cause lymphopenia as part of their mechanism of action. They cause it in some patients as a side effect. So what does this happen? How does this affect the response to vaccination? That's a very common question, especially the dimethyl fumarate in the United States and many other parts of the world is actually the most commonly used MS medication. So a lot of patients are on it, and we don't know the answer to this very important question that will come up in just a few months. And then patients on ocrelizumab or rituximab, we know that after being on those B-cell depleting monoclonal antibodies for prolonged periods of time, you can actually develop hypogammaglobulinemia. You might not have enough antibody levels. I'm talking about protective antibody levels in your blood. So what's the effect of that on vaccination? We do not know. Ocrelizumab is widely used now in the United States and many parts of the world. And many patients really have hypogammaglobulinemia, and we don't know, can we give them the vaccine? That's an important question that was not addressed at all in the study, in that paper. And then number 6 is post-vaccination isolated or monophasic demyelinating events not addressed. So they only did search on MS and vaccination. What about post-vaccination optic neuritis, transverse myelitis, clinically isolated events? If you include those in the search, then the results might have been different. We all know that optic neuritis and transverse myelitis or brainstem CIS, all these are risk factors for future development of MS. When you totally exclude those papers from the literature search, then your results might be really skewed towards less effective vaccination in patients who are prone to demyelinating disorders. So just some examples of the limitation of this paper. Now, I'm not sure about the time. I know we're kind of running behind. I'll leave it up to you. I put 2 bonus slides about COVID-19 in particular. I'll be happy to discuss those or not discuss those based on the audience preference.
Go on, but نكمل السهرة عشان
Okay, I'm only 2 slides. So okay. the 2 bonus slides, just to put this whole journal club is really geared towards what's going to happen once the COVID-19 vaccine becomes available in maybe a few months or 6 months or so. And it's going to be a very important question. Every single MS patient will come with the question, should I take the vaccine? Can I take the vaccine? What vaccine should I take? So this is very, very important. Now, those are all the types of COVID-19 future vaccinations. So those are the vaccines that are being developed currently, either in animal or in human trials. Some of them are live attenuated vaccines, and this will have implications. Of course, those are usually the ones that give you the best protective immune response after getting the vaccine, but they also carry the highest risk of developing an infection if you receive the vaccine while you're immunocompromised. So those are being developed currently. There is a viral vector vaccine. This one is actually in human trials. A viral vector vaccine is when you take part of the SARS-CoV-2 virus and put it in another virus that is less harmful. And currently, I think the study that is going on, so sorry about the noise, the current study is looking at putting the SARS-CoV-2 protein inside an adenovirus that is attenuated, and then giving the live adenovirus with the COVID-19 DNA to the patient. So that's a viral vector vaccine. This is one of the candidate viruses that might be available first, actually. So this is actually considered, we don't know if a viral vector vaccine should be treated as a live vaccine or as a killed vaccine. It's actually is going to be a big issue, but in general, we think of it as a live vaccine at the time being. And then there's an inactivated vaccine similar to the influenza vaccine. And then there is also two newer types of vaccines that are being specifically developed for coronaviruses. They were tested for SARS and for MERS before SARS-CoV-2. And those are not your typical types of vaccine. One is either a DNA or an RNA vaccine. So you're only taking the DNA or RNA from the virus and injecting it. And the other one, which is very similar, is a protein subunit. So you take just the S protein, that spike protein that you see on the virus cartoons and so forth. You just take that part and give it to the patient and see if they will develop a protective response. Of course, the benefits of these is that there's really no virus at all, so they are safe for our immunocompromised patients, but they might not result in a very protective immune response like a full live vaccine. Another important point here is that some of those DNA, RNA, or protein subunit vaccines are called T lymphocyte epitopes or B lymphocyte epitopes. And what that means is when you have a T lymphocyte epitope, means that this part of the vaccine or this part of the virus is more likely to stimulate your T cells more than your B cells. And you get a protective T cell response against the virus, which is unlike most of the vaccines that we use commonly. Why is that important? It is important because we have B cell therapies. So let's say they develop a T cell epitope vaccine and your patient is an ocrelizumab, then they can probably develop a good T cell response against the vaccine because their T cells are intact. They are on a B cell depleting therapy. So that would be an ideal vaccine for those patients who are on rituximab or ocrelizumab once it becomes available, and you'll be less worried about less protective immune response because those are vaccines that mainly stimulate T cell immune response rather than an antibody mediated or humoral immune response. And then of course there are B cell epitopes that will result in a protective antibody against the vaccine. If you are on a B cell therapy like ocrelizumab and rituximab, it's probably not a good idea to give this type of vaccine if you have the choice, of course, because they might not mount a good response to the vaccine. The reason why I kind of looked into this is actually our group working with the pharmacy group at University Hospitals of Cleveland and the neuroimmunology group, we're actually developed that is currently in press and that looking at what are we going to do once those vaccines become available for our MS patients. And of course, there's no data. The vaccines are not even available. So we don't have any real world data to support what are we going to do. And like Dr. Ismail mentioned earlier, well, this is going to be a very common question, and it's going to happen in 3 months, and you will have zero data to support what your course of action. So the best thing to do is to look for the closest evidence. What happened with SARS? What happened with MERS, the other coronaviruses? What happened with the flu vaccine because it's an inactivated vaccine? What is the infection rate for every one of those medications? What is the effect of the vaccine, the effect on vaccines for every one of those medications? What is the actual mechanism of action and the idiosyncratic effect on the immune response of each of those medications? And then you can construct a plan or a protocol on what to do once the vaccine becomes available. So if you don't have science, you at least have to have a plan. And the plan has to be logical and has to be based on similar or, as the AN words it, related evidence as much as possible. So the way we think about it is, you will have either a viral protein, RNA, DNA, or inactivated vaccine And of course, those are not identical, but they are all similar in that they are not live vaccines. Or you're going to have a live attenuated or a viral vector vaccine, which you put it in the same category. When you look at the interferons, we think that interferons have no negative impact on the inactivated viral protein inactivated vaccines. We don't know if they are incompatible with the live attenuated vaccines. There's really no data. So it's even possible to try those live vaccines in those patients. For glatramere acetate, there's some question about a negative impact on inactivated vaccines, and the compatibility with live vaccine is unknown. For teriflunomide, no negative impact on killed vaccines that we know of, but live vaccines are generally not recommended. So again, you have to be careful if a live vaccine becomes available. So for the fumarates, dimethyl fumarate, hydroxamyl fumarate, if the patient is not lymphopenic, there's no negative impact on inactivated vaccines, at least based on influenza vaccine studies. But if they are lymphopenic, we do not know, and you have to be careful because they might not mount a protective response to the inactivated vaccine. So we don't want them to have a full sense of security. You might want to check serology after the vaccination to make sure that they actually mounted a protective response. And then the compatibility with live vaccines is unknown. For the S1P1 modulators, fingolimod, siponimod, and ozanimod, we already know for sure there is a decreased humoral and cellular response in those patients to inactivated vaccines. So checking serology after vaccination is a must, and we know they are incompatible with live vaccines. So that will be the wrong choice for those patients. Natalizumab, there's no negative impact on inactivated vaccines based on influenza vaccine studies, and the compatibility with live vaccines is unknown. So it's safe to give an inactivated or viral protein, or at least we think it will be safe to give those vaccines to natalizumab patients. For ocrelizumab, there will be a decreased humoral response, but not cellular response as far as gathered from related evidence. So will probably be safe to give those T-cell epitope if they ever became available. But if you give something that requires a humoral response, then you have to actually check the antibody level after the vaccination. And we know it's incompatible with live vaccine. Now, alemtuzumab and cladribine both cause non-selective lymphopenia for a number of months after given the vaccine. So they markedly decrease both the humoral and the cellular response to the vaccine, meaning that if you give the vaccine, the inactive vaccine during the lymphocyte depletion phase, you really have to check serology and make sure they are protected. And the odds are they are not going to be protected, and you have to revaccinate them again once lymphocyte repletion happens. And of course, they are also incompatible with live vaccines. That's kind of our attempt to have a plan on what to do with those with the COVID-19 vaccine once it becomes available, stratified by each of the available disease-modifying therapies that are currently in use. And that concludes the presentation. Sorry that it took a long time, and I'll be more than happy to any questions from the audience.
شكرا هشام على البرزنتيشن بتاعتك الجميله دي. انا كده بقى يعني انا بس هعلق تعليقين كده. كنت عايز اعرف بس هل دي بتبقى عندكم الريكومنديشن دي بيبقى لها ليجال كونسيكونسز يعني الماست تفرق عن شود عن بتاع ده بالنسبه للليجاليتي، يعني العيان يعني كليجال سيستم، يعني العيان لازم ماست تفرق عن شود؟
ما اظنش بصراحه، لان يعني those guide حاجه زي ال AN guideline. The AN is just it's a scientific organization. يعني it's not governmental, and it has so anything that is just a scientific organization is treated as a guideline. So I don't think in the wording in such guidelines have any legal implications. But of course, if there is a lawsuit or insurance denial or something like that, you use those papers as supportive evidence. But I don't think it's compelling or has any definite legal obligation.
تاني حاجه بس كان دايما يعني كنت سمعتها من حد اساتذه مش عارف يعني مش فاكر مين، اللي هي absence of evidence is not evidence of absence. يعني لو ما فيش يعني evidence ان في حاجه يعني شغاله او مش شغاله is not evidence of absence of this effect or output effect يعني. فيبقى still we need more research. وبرضك حد من اساتذتنا كان قال guidelines are meant to guide you not to oblige you يعني. فانت ايه الجايد لاينز دي يعني برضك will depend برضك على your opinion في الاخر regarding انت بتقرا جايد لاينز، بتقرا وتعاملك مع العيان depend على your experience و your point of view يعني. في حد
totally agree.
في حد لسه صاحي؟ اسماعيل صاحي ولا نام؟
كلنا صحيين يا اشرف، البرزنتيشنز ممتعه الحقيقه. انا حد مين هينام في
البيرسونز اللي هم اللي هيبقوا صاحيين دلوقتي، المورنينج بيرسونز.
لا والله اليوم جميل وساينتفك كونتنت رائع وفيري جود ستارت للجورنال كلاب في القسم. فانا سعيد جدا جدا النهارده باليوم ده، يعني هتحط في التاريخ بتاع القسم بتاعنا يعني ان شاء الله. واشكر جدا السبيكرز على راسهم طبعا دكتور هشام ومشاركته ووقته معانا والساينتفك كونتنت الجميل يعني، وساره طبعا وايمان واشرف على راسهم، لان انت اخترت الموضوع وعملت الجروب وبتاع. فيوم جميل الحقيقه، سهره ممتعه يعني.
ابراهيم، دكتور ابراهيم، ايه الاخبار؟
منشاوي يا ابراهيم، ازيك؟ منورنا.
عليكم السلام عليكم.
احلى حاجه
انا سعيد علشان
نورث كارولاينا بتجمعك مع بعض هي كلها.
ايوه
احنا اربعه، انا وابراهيم وحازم كنا في نفس المكان في يو ان سي. فاحنا الاربعه كنا في نفس المكان في نفس السكول يعني.
الحقيقه كمان انا مستمتع لان احنا كنا اولموست برضو في المنصوره هنبتدي الجورنال كلاب، فانتوا سبقتونا يعني. انتوا لكم السبق. انتوا لكم السبق. بس هي دي النقطه يعني. انت يعني علشان تقدر تدي الحاجات اللي انت عارفها وان انت عارف انها ممكن تفيد الجونيور ستاف، محتاج somehow يبقى لك شويه authority يعني. ف it's with time يعني. نتمنى ان شاء الله ان احنا ناخد الاقسام بتاعتنا to a next level، بيكون فيها الكانديديتس الصغيرين يعني اقل امبريشن ان هم مش هيبقوا زعلانين وحضرتك سوبرفايزر عليهم وبتقول له صلح دي وعيد دي وغير دي. هيبقى متفهم الكلام ده لانه قدر يفهم البيزكس اوف ريسيرش من something like الجورنال كلاب. دي مهمه جدا for us as academic persons. It's part of our job, very important one, lifelong learning و lifelong job. فانا بحييكم ان انتوا بداتوا، وان شاء الله احنا هنكون اونلاين with you مع حاجات تانية كتير جدا احنا عهدناها وشفناها في الستيتس. ان شاء الله تبقى حاجه جميله
ان شاء الله.
توبك جميل جدا، ميرسي جدا. اول مره احضر توبك ده متكامل كده من تحت لفوق، حاجه حلوه قوي. دكتور هشام قال حاجه very comprehensive الحقيقه، وطبعا في تشيرستك بعد ما اتكلم على الكوفيد وكل الحاجات اللي ممكن تيجي في دماغنا يعني. فمتشكر جدا لتفاعله معانا يعني في مصر.
شكرا هشام، شكرا، الله يخليك. شكرا ابراهيم على حضوركم، شكرا على جميع الحضور. ويعني معلش مد شويه الوقت، لكن يعني ان شاء الله يكون الكل استفاد وكل يعني مبسوط في الجورنال كلاب ده. وان شاء الله يعني ننسق بعد كده، يبقى ان شاء الله كل شهر مع دكتور سامح ودكتور حازم، يبقى ان شاء الله نخليه نحافظ عليه
ان شاء الله. ان شاء الله ان شاء الله.
ميرسي جدا، كل سنه وانتم طيبين.
شكرا، تصبحوا على خير وشكرا.
شكرا يا شباب، اشوفكم بخير ان شاء الله.
شكرا يا جماعه، السلام عليكم.
شكرا جزيلا، متشكر جدا.
شكرا يا هشام، ميرسي خالص. السلام عليكم، مع السلامه.